The next presentation is on ruptured sinus of Valsalva by Durga, Bhavani and Swathi.
Before you to present a very rare case of cardiac abnormality, there is rupture of sinus of Valsalva. Here is the case history of the patient. He is a 50-year-old male patient who was brought to our hospital, who is a daily laborer with chief complaint of shortness of breath, abdominal distension and pedal edema for the past 30 days. Shortness of breath is insidious in onset and progressive in nature. He also gave a history of one episode of chest pain 4 months back while he is doing his work, which got relieved on taking medication. He is a known diabetic and hypertensive. He is not known diabetic and hypertensive, asthmatic and epileptic, and no history of congenital heart disease and sore throat and joint pains in childhood. And there is no history of chest trauma and significant past medical or surgical history. His personal history is quite normal except for the sleep pattern which got disturbed because of PN and orthopnea. He is a known alcoholic and tobacco chewer for the past 30 years. Coming to the clinical examination, he is conscious, coherent and cooperative. He is pale and bilateral pit and pedal edema is present. No signs suggestive of icterus, cyanosis, lymphadenopathy and clubbing are present. His pulse is 90 per minute, regular high volume pulse, normal in character, no radioradial or radiofemoral delay. His blood pressure in both upper limbs is 100 by 60 millimeters of mercury and both lower limbs is 150 by 70 millimeters of mercury. His respiratory rate is 22 per minute and temperature is 90.6 and JVP is elevated 11 centimeters above the sternal angle. Both A and B waves are increased. Coming to the CVS examination, on inspection chest is bilaterally symmetrical and apex bit appear to be in the left 6th intercostal space, half an inch lateral to mid-clavicular line. Left parasternal and suprasternal pulsations are present, no visible signs or engorged veins. On palpation, apex bit is confirmed to be in the left 6th intercostal space, half an inch lateral to the mid-clavicular line, hyperdynamic in nature. Continuous thrill is felt in left 3rd and 4th intercostal space, no palpable heart sounds. Left parasternal pulsations are felt. Coming to the auscultation, on auscultation both S1 and S2 are heard with normal split and grade 4/6 continuous high-pitched murmur is heard in left 3rd and 4th intercostal space. On examination of the other systems, on respiratory system, bilateral vesicular breath sounds are heard with decreased intensity on the right side and per abdomen is soft and mild tenderness is elicited in right upper quadrant. Sinus is found to be normal. Coming to the investigations, routine blood investigations are done like hemoglobin, total leukocyte count and etc. Liver function test showed slight elevation in alkaline phosphatase levels and total bilirubin is also elevated. Thyroid profile showed increase in TSH levels. Renal profile level appears to be normal. Here is a 12-lead ECG showing sinus rhythm and normal axis. The pointer is showing that the sum of S and R waves are increased. Sum of is greater than 35 millimeters, indicating LVH. Here is a chest X-ray PA view showing cardiomegaly and mild pleural effusion on the right side. This is a transthoracic echocardiography, parasternal long axis view showing the left ventricle, right ventricle, and there is aneurysmal dilatation opening into the right ventricle. On the right side, you can see the mosaic pattern of flow from the aorta into the right ventricle. This is the parasternal short axis view at aorta level showing right coronary sinus dilatation and the mosaic pattern of the flow into the aorta during diastole. This is CECT of chest showing This is CECT of chest showing contrast filling simultaneously in both left ventricle, aorta and the right ventricle, indicating there is an abnormal flow from the left chambers to the right chambers. This is a 3D volumetric reconstruction of CT showing aneurysmal dilatation of right coronary sinus at the base of the aorta. This is the cath report LV angiogram taken in left anterior oblique view showing here the catheter is placed in the left ventricle and dye is injected. We can see the leakage of the dye from the aorta into the left ventricle. Aortic root angio in left anterior oblique view. Here the catheter is placed inside the aorta and the dye is injected. We can all see the dye is leaking from the aorta into the left ventricle, indicating there is a way from the aorta into the left ventricle. This is the final CAT study showing that his coronaries are normal, and they gave that there is a rupture of sinus of Valsalva arising from the right coronary sinus and opening into the right ventricular outflow tract. Advised surgical closure of rupture of sinus of Valsalva. We managed the patient until surgery with stabilized the patient with diuretics and supportive measures, and we subjected him to closure of RSOV and strengthening it with pericardial patching. Here's the first picture we took as soon as the chest is open. Here we can see the aorta, pulmonary trunk and the right ventricle, and also aneurysmal dilatation of right coronary sinus very close to the right coronary artery. This is a picture showing the ruptured sac of right coronary sinus opening into the right ventricular outflow tract, opening of ruptured sinus into the right ventricular outflow tract. This is a pericardial patch they're using to close the RSOV. Is the intraoperative transesophageal echocardiography showing that there is no abnormal communication between the aorta and the right ventricle. Is the postoperative transthoracic echocardiography showing no abnormal communication. Is the seventh post-op day picture of the patient. He's recovering well. Coming to discussion, aneurysm of sinus of Valsalva is a rare cardiac abnormality, which most often it coexists with other congenital cardiac abnormalities like VSD. These are nothing but what is sinus of Valsalva is dilatation of the aortic wall immediately superior to the attachments of the three aortic valve cusps. Pathology underlying it is defective aortic media. There is no continuation of elastic layer of the media between the aorta and the annulus, aortic valve annulus. This results in the subsequent dilatation of the weak point due to high pressure sites. Outcome, if it gets ruptured, it results in acute clinical syndrome. If it is unruptured, it remains asymptomatic till diagnosed. This is the case sheet of the patient.
What is the differential diagnosis for RSVV?
Patent ductus arteriosus, VSD with AR, and coronary AV fistula and RSOV. Sir.
How do you differentiate from PDA? Clinically. So
Clinically, ECG.
What are the features of PDA?
Continuous murmur, sir.
Yeah, but here also there is a continuous murmur. There also it is
peak
continuous
flow
murmur.
in second heart sound will be more in PDA, sir, when compared to RSOV.
Okay. Any other feature?
Echo differentiates the...
No, echo clinically, so there is a continuous murmur. PDA also will be continuous murmur. So you said one point. Next, any other site of the murmur where it is better heard or something? You said here the third and fourth space.
Yes, sir.
PDA murmur?
Left second
Correct.
second intercostal space.
Second and first space. It
First-
is little
first and
higher
second
side.
and
It is a
higher
lower
side.
side. Okay. What are there any other feature? Continuous murmur? What are the various sites of rupture of Valsalva aneurysms?
It can, if it arises from the right coronary sinus, usually it gets ruptured into the right ventricle, sir.
Good.
From the non-coronary sinus, it ruptures into right atrium. If it arises from the left coronary sinus, it ruptures into the left ventricle. It is usually rare, sir. It's 5% of incidence from the left coronary sinus.
If it ruptures into the left ventricle, what are the features?
Regurgitation. Regurgitation symptoms, overload.
So, will you get what murmur? Suppose if it is rupturing to the left ventricle,
Pansystolic.
regurgitation when there is aortic regurgitation. Aortic regurgitation.
Mid-diastolic. Sir, repeat the question, sir.
What is murmur that is produced by aortic regurgitation? When there is aortic regurgitation, what is the murmur? What is the definition of continuous murmur?
It starts from the systole and extends into the early part of the diastole, sir, including...
Any medical treatment?
Yes, sir, we stabilized the patient with diuretics till we subjected him to surgery and supportive measures to decrease the overload on the heart.
Final treatment is
After cardiac surgery, after surgery, extent of recurrence. What are the precipitating factors for recurrence, if at all?
Again,
severe exertion after surgery also. If the patient is on continuous work, daily routine work. He was a farmer by occupation, daily laborer. So on exertion also, maybe or any trauma, history of trauma.
any chest trauma.
So what did you advise him? Okay, you've not seen the...
Less exertion works.
Okay then, fine.
Thank
Good.
you, sir. Thank you, sir.
Questions from audience?
Videos play over here.